this video, we will discuss Dacryocystorhinostomy. We will go through the step-by-step technique of conventional external Dacryocystorhinostomy, a core procedure in ophthalmology. External Dacryocystorhinostomy is indicated when the obstruction lies distal to the common canaliculus, most commonly in primary acquired nasolacrimal duct obstruction, secondary acquired nasolacrimal duct obstruction, congenital nasolacrimal duct obstruction after failed probing or intubation, and in history of dacryocystitis. The surgery is usually performed under hypotensive general anesthesia to reduce bleeding with the patient in supine position. However, local infiltration anesthesia can be given in adults, and nasal packing is done using a vasoconstrictor. The procedure begins with a vertical skin incision placed about 10 mm medial to the inner canthus, carefully avoiding the angular vein. Then, the medial palpebral ligament is exposed by blunt dissection and is cut with scissors. The anterior lacrimal crest is exposed, the periosteum is incised, and the lacrimal sac is carefully dissected free and reflected laterally from the lacrimal fossa. Next, the anterior lacrimal crest and the adjacent lacrimal fossa bone are removed to create a bony ostium communicating with the nasal cavity. The lacrimal sac is then incised in an H-shaped fashion, creating anterior and posterior mucosal flaps. The nasal mucosa is also incised in an H-shaped pattern, giving corresponding anterior and posterior flaps. The posterior flaps are sutured first, followed by suturing of the anterior lacrimal sac flap to the anterior nasal mucosal flap, establishing a mucosa-lined fistula. After achieving hemostasis, the medial palpebral ligament is sutured to the periosteum. The orbicularis muscle and skin are closed in layers. Orbicularis muscle is sutured with 6-0 vicryl and skin is sutured with 6-0 silk. Nasal packing is removed postoperatively. External DCR has a success rate of over 90% when a well-positioned and adequately sized ostium is created. Failures may occur due to an inadequately sized or malpositioned ostium, missed canalicular obstruction, excessive scarring, or the sump syndrome, which occurs when the surgical opening in the lacrimal bone is too small or too high. Possible complications include scarring, injury to the medial canthal structures, hemorrhage, infection, and rarely cerebrospinal fluid rhinorrhea. Endoscopic Dacryocystorhinostomy. Endoscopic DCR encompasses several techniques. A light pipe can be passed through the canalicular system into the lacrimal sac to guide an endoscopic approach from within the nose, or a microendoscopic transcanalicular procedure can be performed using a drill or laser to establish communication with the nasal cavity. The advantages of a conventional DCR include minimal blood loss, less systemic disturbance, lower risk of CSF leakage, no skin incision, and shorter operating time. Disadvantages include generally a slightly lower success rate and visualization difficulties, meaning that additional procedures are sometimes needed.